Hey, my name is Dr.Joe and today the 26th of February 2025 and today we have a very interesting surgery. Now I just want to remind you that we're just about to get to March, which is Endometriosis Awareness Month. Now this is a patient who's had chest pain for years and she's been getting tapping or draining of the fluid. Over years, she has actually developed symptoms of difficulty breathing, and this pain chest has worsened. Initially, she was getting drained maybe once every 6 months, but over the last few months, she's actually getting drained twice a month, which is actually quite interesting. We have a multidisciplinary team. What I mean by that is we're going to have different experts. And particularly for this case, we're going to have an expert who is a cardiothoracic surgeon. And for this he will be introducing a camera into the chest cavity, just visualize the disease and excise this disease out. And it's going to be very interesting. The second phase of this surgery now will be us, the gynecologist, will put scope inside the abdomen, and we'll be checking inside the abdomen, seeing how the pelvis is looking like, and just going to determine. So this is a very interesting case. It's not very often you get to see endometriosis of the lungs specifically. Yes, we see of the diaphragm, but infiltrating the chest is something that we don't commonly see. So that's the beauty about multidisciplinary team and having a facility that have different specialties in terms of management of endometriosis. So we're just about to start. We're not really sure how long this will take. It's all just going to depend on the situation. So yeah, we're all set for this. Very excited. Hope that we can sort our issues out. Let me. So basically what we found that there's endometriosis on the lower lobe of the right lung, and this is possibly what has been giving her a lot of issues with breathing and respiratory distress. But more to that, there's still more endometriosis that is infiltrating the chest wall. So what we are currently doing, we are cutting off part of the lung which has disease, and then we are going to scrape off the disease that is on the chest wall. So things are progressing well. It's a difficult procedure because of the manipulations and the angles, but at least we've been able to find the disease and we're able to reduce some of the disease. So the progress is pretty good. So basically we finished the surgery, and the first part we had explained was the upper part, the chest. We found she had endometriosis of the lungs and the chest wall. So we've done the second part of the abdomen, and we found that she has extensive disease on the pelvis. The uterus is completely infiltrated. We found that the diaphragm from the abdomen is actually also infiltrated with endometriosis. We also looked inside the bladder, and we also found that the bladder has also been infiltrated. This means there's a very high likelihood that also the intestines has been infiltrated. So I would say she has the endometriosis of the pelvis, she has endometriosis of the bladder, she has endometriosis of the bowel most likely, endometriosis of the diaphragm, endometriosis of the chest, endometriosis of the lung. This is like a full-blown endometriosis. So we've done the chest today. So the second phase of the surgery, which will be, a
a few months from now, now just clearing endometriosis in the pelvis, in the bowel, and in the blood.
Obviously, this is not the kind of case that you would approach without a full multidisciplinary team approach. So we've just concluded the thoracic VATS procedure for with our thoracic surgeon. We've had to do, she's a patient who's had over 10 times chest drainage with over 500 to a liter of fluid. Today, as we did it, she had an effusion of over 700 ml. We've drained all that, we've explored, we've done a resection of the thoracic, of the lung with the nodule of endometriosis, and subsequently also done fluorodesis. Not the kind of case that we would like to obviously get into over and over. A very complex case that definitely is not very easy to be done unless you have a full-fledged endometriosis center and a full multidisciplinary team.
The patient does have thoracic endometriosis. Now, thoracic endometriosis can present in a couple of ways. Endometriosis is a whole separate topic which involves endometrial tissue being far away from where it should be. Endometrial refers to the tissue being within the uterus. Now, away from the uterus, it can be inside the muscle of the uterus or just adjacent to the uterus in the intestines and the pelvic area. But we do know that endometriosis can go further than that, carried away by the bloodstream, and can find itself in any tissue of the body, but commonly in the lung. We've seen this a lot of late, and we're managing this successfully with the endometrial team here at Third Park Avenue, and we've had a few success stories. Now, what happens is when it spreads to the lung, it can present in a couple of ways. One is patient starts developing fluid in the chest, and with the lung collapse that can come with it, or they can develop air leaks, because when there's endometrial tissue affecting the lung is actually a bubble of air, and it can just leak out air and get you something called a pneumothorax. Now, pneumothorax can be quite disastrous because if the lung collapses and the air isn't going anywhere, it forces the lung to completely go down and push the heart and affect the opposite lung, and you get what we call a tension pneumothorax. And when you get the finish, when you connect the
Yes.
Now, with the fluid, what some patients will notice, like I have a young lady I sorted out recently at another hospital where they presented having had chest tubes put in practically 10 times, and every time nobody would tell them what's wrong, just whatever. And just a simple interview by one of my younger colleagues brought out that it might be what we call endometriosis, because it's related to the periods. And when she gets her periods, she gets a chest pain. When she goes to the hospital, they find that there's an air leak, and they put a tube and they discharge her. But they never quite tied the two up that it could be endometriosis. And when we went in, we just saw the endometrial tissue and sorted it out. Now, a couple of ways to sort out the endometrial lung disease in the lungs, thoracic endometriosis. Now, of course, the first thing is put in a chest tube to drain the fluid. If it's an air leak, you have to put in a chest tube to drain the air, allow the lung to re-expand. Now, beyond that, once we go in with what I'm doing nowadays called the video-assisted thoracoscopy, I'm able to stick a camera in the chest, and through that we're able to visualize the lesion, and we can scrape the lesion out, we can excise the lesion. Commonly it's on the diaphragm, and sometimes they're so tiny and punctate that all we do is scrape it up and try and peel off the lesion. If it involves the lung, like we've done for this patient where it was a big tumor-like thing involving a significant part of the lower lobe, we isolated that area using a stapling device and removed the part that was giving us disease. And hopefully this should sort out the patient out.